Yeah, we're recording.
Sweet. Okay. Well, hello everyone. Welcome to this second lecture in this SPLICE series. So for those of you who don't know me, I'm Chris. I've just finished my finals at UCL. So to start with, I'd just like to say thank you on behalf of Shwet and the whole team really for the feedback from the last lecture. It's really helpful, and it kind of means we can target these lectures to the best level and make them as useful as possible. So thank you for that. And yeah, so we put these presentations together based off the UCL curriculum maps, and we tried to cover sort of the key topics that will help in exams and then clinical medicine in general. So hopefully that's coming across. So yeah, welcome to this ortho lecture. The plan is to try and make this as high yield and SBA based as possible in this hour and a half. I'll also talk through a few of the key aspects that I've written on the slides, so you can view it afterwards. And then should hopefully provide some help if you're struggling with what to revise for ortho. So yeah, so this is what I've included. Basically, a lot of information is in the kind of joint pathology section at the end, which I'll go through briefly, but it'll be something to flip through in your own time. So in the higher yield stuff, I've tried to put at the start. Cool. So then the learning objectives are a little bit all over the place for ortho, so I've tried to simplify these down as best as possible, really. I do a little bit on x-rays because that sort of thing does come up occasionally in the exam, and then the rest I've tried to include what seems to be sort of the most pertinent aspects of each objective. Right, so just a little bit of bone physiology to start. Hopefully this will kind of ring a bell for those of you who are traumatized a bit by pre-clin years. But this is basically all you need to know. I've nicked this slide from Osmosis because I think they cover it really well. There's basically two types of bone. You've got your cortical bone and then the cancellous and spongy trabecular bone. The cortical bone is the protective element on the outside with these sort of long, like tube-like structures called osteons, and they're made up of these concentric rings called lamellae. And these are a bit like rings on a tree. These lamellae contain made up of collagen and something called hydroxyapatite, which is your body's stored calcium and phosphate. Osteons have a canal in the middle, which then provides the blood supply and the innervation. And they're very well innervated, which is why it hurts so much when you break a bone. Then the inside of the bone is made up of your trabecular bone, which is sort of beam-like structures, provides strength and support, and then they've got some gaps. The bones are so heavy that you can't move. And then finally, you've kind of got this constant process of bone remodeling. So you've got your two cells throughout the bone tissue, your osteoblasts and your osteoclasts. The osteoblasts are there to build the bone, to increase the strength of bones, heal fractures, and can lower your body's calcium levels by adding to these calcium phosphate stores. And then osteoclasts resorb bone tissue to help remove damaged or fractured tissue to maintain optimum bone strength. It can also release calcium stores if required. So normally these work in harmony, and there's an equal rate of production and resorption. But if for some reason this goes out of balance, then you can get conditions like osteoporosis. And then just a quick bit of endo that I think is quite useful to know. Bones play a really crucial role in calcium homeostasis, which is a process primarily modulated by hormones. So you've got parathyroid hormone at the bottom there, which is released in response to low serum calcium levels. This causes an increase in osteoclast activity, causes resorption of bone, and that releases calcium into the blood. Calcitonin does the opposite. So if there's high levels of calcium, it's released from the thyroid gland, and then the osteoblasts take calcium and make it into bone. And so just on a note about vitamin D causes increased calcium uptake in the gut. So this raises serum calcium. So calcitonin is activated to move the calcium from the blood and into the bone. So if you don't have enough vitamin D, you get a condition called osteomyelitis, whereby there's insufficient mineralization of the bones because there isn't enough calcium to effectively mineralize and build bones. So the first SBA here. So hopefully this works. If log on to the VBox. And I'll give sort of 45 seconds or so to a minute. Cool. Isaac, if you want to shut the poll when we've got roughly a decent set of numbers. Okay. Right. This is so I put this in as a very difficult question, just to start with. And basically, it's a difficult question because it requires you to know a bit about osteoporosis management. And basically, I've thrown in some things that might catch you out. So it's quite a difficult question, this one. So basically, why do we know she's got osteoporosis? So we've done a DEXA scan and she's given a t-value of -2.6. Anything sort of lower or more negative than 2.5, -2.5 is a diagnosis of osteoporosis. But then without that, why might we sort of suspect? Well, she's having a sudden pain in her lower back on lifting her grandchild. Differentials are possibly like a slip disc. But yeah, maybe muscular, but basically it could be a vertebral crush fracture. That's what it's trying to get at. A postmenopausal woman in SBA land, we might be able to assume she's quite frail. She's taking steroids for a lung disease, another risk factor. So good. You've got that this is osteoporosis. And going through the answers, basically bisphosphonates are first line, but there are a few contraindications to oral bisphosphonates. And particularly any esophageal disorders. And in this case, she has suspected varices. So therefore, bisphosphonates would be contraindicated. And basically then this goes to your second line management, which is your denosumab. And I'll come on to this, I've got a slide on sort of the pathway. But basically an overview of osteoporosis. So this translates to porous bone. So there's a decreased bone density, leaving increasingly larger gaps within the bone structure. It basically occurs when the resorption of the bone is greater than the building of the bone. So this means the osteoclast activity is greater than the osteoblast. So you're taking away more bone than you're building. Then there are these fewer and fewer of these trabecular beams that act as a structural support because they've increasingly been absorbed. And then the bone can collapse in the case of a crush fracture. Or has less resistance to force and so fractures more easily. And then bones which contain more trabecular bone, so shoulder blades, vertebrae and ribs, are therefore more at risk of fractures. Biggest risk factor is menopause because you lose your production of estrogen. And the reason it's important is because estrogen is a key regulator of osteoclasts. So without estrogen inhibition, they go a bit crazy and resorb the bone at a much faster rate than the osteoblast can make bone. And in most people, this is a slow enough rate that it's not an issue. But then when you have other risk factors tied in, or your bone's already quite thin, it can cause problems. So the other risk factors being low serum calcium, alcohol, smoking, and steroid use, because they can all resorb the bone or reduce the bone density quite quickly. The reason steroids are a risk factor is because they antagonize vitamin D action in the gut, so they prevent calcium absorption, which so reduces the amount of calcium in the bones. And then you've got a few treatments. Basically, weight-bearing exercise puts stress directly on your bones. The stress put on your bones activates the osteoblast to lay down more bone to prevent a future fracture. So basically, the more weight-bearing exercise you do, the stronger your bones will be. And then, so this is the treatment pathway for osteoporosis, and I think this is quite a clear way of going through it. You can basically enter from one of two routes. Either you've got a fragility fracture, and that's your presenting complaint, so you've got a hip fracture or a vertebral crush fracture, or the GP has recognised some risk factors, which has prompted an assessment. And then you do this fracture risk assessment called a FRAX, which is basically a bit like a Q risk score which you do for heart disease. and it's your 10-year risk of a fragility fracture. And then if this comes out as greater than 10%, you send them on for a DEXA scan, which measures the density of the bone in either the spine or the hip. And then if that comes out with a score of more negative than -2.5, you start treatment and you work your way down this treatment ladder. So like we said, you start with your bisphosphonates, but there are a few contraindications. And then if that's the case, then you move on to your denosumab. Yeah, so this is just a summary of that ladder. I won't really read this out now, but if this is, you can go through this. Basically, you should only need the top left box, looking at your bisphosphonates, your top right second line, and then other things to think about will be calcium levels and vitamin D. Okay, on to the next SBA. So if we can, there we go, cheers. And then again, feel free to shut the poll once you've got a decent number of responses. Okay. Again, I apologize. I've started with two tough questions. So this question is basically an assessment of orthopedic emergencies and then also some complications of trauma operations. So basically, what's happened here is there's a woman who's had quite a nasty fracture in her lower leg from a car accident, and then the orthopedic team thought that it's necessary to do an operation to put a support rod inside the bone and fix the fracture. So that's your intermedullary nailing to fix the fracture. So then what's happened 2 days later, she's complaining of gradually worsening severe pain. So absolutely, this sounds like we're going down a bit of a compartment syndrome route. But she's found to be febrile. Her foot pulses are present, and she's got this raised white cell count and raised inflammatory markers. So what we're thinking here is that this sounds like an infection. So this is osteomyelitis, the most common cause of which is Staph aureus, and so it's the IV flu pox, which is the correct answer here. And it's just a key complication to be aware of for any orthopedic operation, but even more so in the emergency setting with an open fracture, because with an open fracture, the bone's gone through the skin, and there's now just a clear pathway for bacteria to get inside. So before the op, prophylactic antibiotics will be given and the wound will be thoroughly clean beforehand, but it's not always effective. Usually they'll use some broad spectrum antibiotics like coamoxiclav or cefuroxime, and metronidazole to prevent any infections. So then just going through the other answers, so fasciotomy is used in compartment syndrome, so where the inflammation blocks the blood supply and causes nerve and muscle damage, which gives you the severe pain. But this would happen over hours, crucially, rather than days. So that's another reason as to why this is more likely to be an infection rather than a compartment syndrome. DVT is a complication of operations, but the vignette doesn't suggest red hot swollen leg or PE signs. And then surgical debridement used for necrotizing fasciitis, just something to bear in mind if the situation gets worse. But we want to try IV antibiotics first. And then pain relief should always be given, but this won't actually treat the problem. So a few points here on osteomyelitis. It's pretty nasty and it's quite hard to treat. It's often caused due to poor vascular supply to the bones. So in conditions like diabetes or alcoholism, so these can be risk factors. Prosthetic limbs are another big problem because they provide just a perfect surface for a biofilm of bacteria to develop and wreak havoc. And then MRI is the best investigation. And patients are going to need a long course of antibiotics to treat. A 6-week course is recommended. So then the other key differential here is compartment syndrome, and this is another area that question banks and things like that love to test you on. And basically what happens in compartment syndrome is the pressure increases to a level that it prevents perfusion, and the nerves and muscles can die. And you get this severe pain a few hours after an operation or applying a cast that's too tight, because basically there's nowhere for the blood to go or the inflammation to go, and so it starts to expand in this fixed space and blocks the blood supply. It's a late sign for you to get peripheral pulse absence. Severe pain is usually the most common presenting sign, and it's usually kind of out of keeping with the clinical situation. There's classically this pain on passive stretching, so somebody just wiggling somebody's toes causes excruciating pain, and the management involves cutting or loosening any dressings, or then emergency fasciotomy to release that pressure. Basically, if you suspect this, sound the alarms and get help, because the muscle can die quickly. But again, just to differentiate between the two, osteomyelitis infection will happen a bit later. Compartment syndrome is within hours of the operation. Okay, so another question here. If we can get the poll up, please. Thanks. Okay. All right. So so this question is testing the knowledge of back pain and red flags in back pain, or the absence of red flags in back pain. So what we've got here is a relatively young man, and he's got lower back pain brought on by a straining activity, so lifting this plant pot, and then he's got this quite classical symptoms of sciatica. So he's got the pain down the back of his leg, only the back of one leg, and then it's the same foot, the same leg, but there's a bit of weakness and a bit of numbness, but he's basically okay. All other findings are normal. And so the current guidance is for a slip disc, is to prescribe some pain relief and to manage with physiotherapy. So you say here, so the likely diagnosis is this disc prolapse, and then the first line management for this is just advice, reassurance, NSAIDs, and then a bit of physiotherapy, get them up and get them moving. To go through some of the other answers, so the other two popular answers were A and B. So a lumbar spine X-ray isn't actually routinely offered. All that would really show would be whether or not there was a fracture. It's not going to show any soft tissue or nerve damage. So that's not routinely done unless you're suspecting a fracture. And then whole spine MRI is only offered again if it's likely to change the management, or if there's a suspicion realistically of malignancy or Cauda Equina. It can sometimes be offered if the symptoms persist for longer than 6 months, but there's often quite a waiting list for an MRI scan. So for someone with just a simple slip disc and no significant red flags, and that won't routinely be done. So I've got another question here, and then we'll go through some of those red flags and how to pick them out of the question. Okay, very nice. This is good. So correct answer is C. Yeah. So pain in the thoracic spine. So basically, yeah. So a question on red flags, and thoracic back pain is an unusual feature and maybe suggestive of something sinister like a malignancy. To go through some of the other answers, your positive straight leg raise test is just a test of nerve irritation. Nerve root irritation, that's not a red flag. Pain over the sacrum, not a red flag. There's loads of causes. So it could be like ankle spondyloarthritis, like we said. And then unilateral pain is much less worrying than bilateral, because in unilateral pain, all that's happening is the slip disc is just compressing the nerve root on one side. So it's gone, the sort of prolapse has gone sideways. If the prolapse goes back and compresses the spinal cord or the roots coming out of the spinal cord, compressing the whole thing, then that's much more worrying because it's compressing the central cord rather than just the roots. And yeah, so unilateral again. So back pain, one of the most common complaints to the GP. I think it's something silly like 80% of people in the UK will complain about it at some point in their life. But back pain can be for a number of reasons, and most of the time it's not a problem. It's self-limiting and can be managed with painkillers and physiotherapy. So, for instance, spasm of the muscles lining the spine can cause really quite severe pain. It's actually benign and will resolve itself. But there are some serious pathologies, and it's worth knowing these red flags to be able to spot those serious pathologies, because this is a question, if they're going to do an ortho or GP question, this is one of the topics that will be covered. So just there's a few causes, and it's often split up in age groups. And they tend to be worried about the extremes of ages. So young people, it's much more concerning, and in much older people, it's concerning due to could be something sinister like a malignancy. So what I've got here is a list of red flags. And I think these are quite useful to learn. Like I say, just because you can tease these out of the SBA questions, and that's when you'll know to be concerned, to get senior help, to send them in, to order that MRI, rather than just giving them the painkillers and saying physiotherapy. So, like I say, young or old patients should be investigated. This alternating or bilateral sciatica resulting in weakness of both legs might indicate spinal or even a central nervous system injury. And then back pain whilst taking steroids is concerning. Thoracic pain or pain on lying down is worrying. Night pain as well, also concerning. As is previous cancer, someone who previously had cancer and now has pain, because we're worried about metastases to the bone. So yeah, I think these are a good thing just to go through, and just make sure you're roughly familiar with the list and the common ones. Now, this is just a quick slide on disc disorders. So in a prolapse, this disc is made of these annular rings with a mushy center called the nucleus pulposus. If the rings are damaged, the pulposus can balloon out a bit and irritate the nerve root on one side. So this is what happened in our first question. And they're usually managed conservatively. You only really investigate features of Cauda Equina, or the pain has lasted longer than 6 months despite physiotherapy and painkillers. And then also discs can degenerate and dehydrate over time. They sort of deflate basically until you're left with two vertebrae grinding on each other, which is, I guess, understandably quite uncomfortable. And that's your osteoarthritis of the spine. Right, another question. Okay, cool. So we've got a bit of a mixed picture here. So this is a question on testing your knowledge of bone metastases. Basically, the X-ray is showing what's known as sclerotic bone lesions. So this is where the cancer is spread to the bone, and it can either eat away at the bone, causing what we call lytic lesions, or it can cause inflammation and collection of thickened bone, which is the sclerotic lesions. So basically, what you can see in this X-ray is sclerotic lesions, and these are areas of increased absorption. So normal bone looks like this right femur, where you can see kind of it looks quite nice, good bit of density. And then these sclerotic lesions are these areas of white throughout the pelvis, where it sort of looks a bit cloudy and thickened. And so then basically you had to work out what causes sclerotic and what causes lytic lesions in the bone. So the majority of people, 35%, work for Paget's disease, which is good. So that also causes sclerotic lesions in older men. But with this history of weight loss and a normal ALP, is more like to suggest prostate cancer rather than Paget's disease. So the normal ALP here is really just to rule out Paget's disease. The X-ray doesn't show a dislocation, and then that leaves you with your three cancers. Lung and renal cancer more likely to cause a lytic lesion. Prostate cancer, it's very common in an elderly man, and it's the most common cause of a sclerotic bone metastases. So malignancy to the bone is something to be aware of. When somebody taught me about the cancers that commonly metastasize to bone, being the 5 Bs, so breast, kidney, thyroid, prostate, and bung. It's a bit stupid. It helped me remember it. It's there if you want it. But yeah, basically alongside that, I've added the lesions that they commonly cause. So breast can cause both a sclerotic or a lytic lesion, and then renal, thyroid, and lung predominantly produce a lytic picture. So punched out areas of bone, and then prostate cancer will commonly cause a sclerotic metastasis. So if you see that in a question, sclerotic bone metastases, then it's likely to be prostate cancer. The other thing that can be quite useful if you're not sure about cancer questions, think about the populations and the reason why they've told you things in a question. So in this question, it was an elderly gentleman, 90 years old, very old men, it's likely to be prostate cancer. If they're middle-aged and a smoker, it's likely to be lung cancer. If they're a slightly younger woman, it's more likely to be breast cancer. So just little things to think about. Why have they told me this in the question? Right, on to another SBA. Yeah, excellent. So 100% of you got this one correct. So this is brilliant. So this question is kind of just going back over what we've just done, but it's about your ability to recognize those red flags and crucially recognize Cauda Equina, which is one of the sort of key emergencies in spinal stuff, but also orthopedics. Things to think about Cauda Equina, like you've all picked up. So back pain, urinary retention, saddle anesthesia, some leg neuroscience. These should all be prompting thoughts of Cauda Equina. And if you suspect it, like you've all gone for, you need a whole spine MRI in under 4 hours, or it's supposed to be under 4 hours, but crucially under 24 hours, because it needs to be caught early, treated urgently, to prevent paralysis. So this guy's had pain for a few months now, so it's likely a prolapsed disc, but that's now suddenly compressed the whole of the spine, or the whole of the Cauda Equina. So options A and C are insufficient. And then B is not good enough, like we said, so lumbar spine won't be enough to show the soft tissue damage, and then it's not a stroke, so the CT head's not required. Excellent. So then, what is Cauda Equina? So the spinal cord, it stops at the level of L1. So below that level, it's all lower motor neurons, and basically the branches, the nerve roots branch out what looks like a horse's tail. That's the Cauda Equina, Latin for horse's tail. And then basically L4, the L4, L5 disc and the L5S1 disc are the most common sites for a disc herniation in all the back. And normally they don't really cause a problem because they can herniate sideways and will only irritate the nerve roots. But if they compress the whole of this area, then it can put a patient at risk of paralysis and needs to be dealt with urgently. And like we've discussed, the danger signs are severe back pain, saddle numbness, incontinence of both urine or feces, a poor anal tone, and then some paralysis or sensory loss in the legs. And yeah, so urgent management is referring to neurology, and you need that MRI. Okay, so on to fractures, and basically these are the 4 R's of orthopedics. So first of all, if somebody's had a fracture or an injury or some trauma, you need to resuscitate the patient first and make sure they're stable. Once you've done that, then you'll aim to reduce the fracture, and this is to help with pain or prevent infection, and then restrict the movement to allow healing. Allow the bone to heal in a good place, and then you'll rehabilitate the patient to allow a return to function. So the types of fracture, here we've got all the different types of fracture. Transverse fractures, where the bone is broken clearly across the shaft, and this is usually the result of a bending force. Then you've got oblique fractures. This is curved or sloped fracture, often caused by a compression. Then you've got a spiral fracture, which is a twisting injury, where torsion of the bone causes this spiral-shaped fracture. A common cause of this is somebody getting their foot stuck in a ski boot, which is fixed, and they catch their ski and the leg twists around and causes a spiral fracture. You've got comminuted, which is breaking or splintering of the bone into more than 2 pieces. An avulsion fracture, so this is where a little bit of the bone is ripped off by a tendon or a ligament. So a common place for this to happen is at the malleoli in the ankle in an eversion or inversion injury, and with sufficient force, the ligament can pull off the edge of the bone. Rather than snapping itself, it pulls off a bit of bone, and that's your avulsion fracture. Impacted, 2 ends of the bone basically just smash into each other, again sort of compression or an impact injury. Fissure is a crack in the bone itself rather than actually splitting. And then you've got green stick fracture, which occurs in kids, and this basically happens as kids have got more malleable bones, and so when the bone bends, the sort of inner side is supple enough to take the force, but the outside kind of splits, and it's called green stick. Like if you ever take a branch that's still on a tree and you try and snap it, it doesn't satisfyingly snap, it kind of splits at one side a bit like this. So then just a little bit on fracture healing. So we've resuscitated the patient, reduced the fracture, restricted it, and now the bone has to heal itself. So the first thing that happens is there's a big swelling, formation of the hematoma with bleeding into the fracture, which basically causes a big inflammatory reaction. This leads to cell proliferation, and then the early bone and cartilage is formed, which is called a callus. Then there's some consolidation occurring where the callus becomes woven bone, which is quite disorganized, and then this is replaced by more organized lamellar bone. And then the bone's put under its normal stresses and kind of remodels over months to years back to its normal shape. And then the time this takes varies on the blood supply to the fracture and the person's age. So children heal very quickly, but elderly people with really poor blood supply will take a lot longer. And then this is something you might have had to do in your orthopedics placements. This is sort of describing a fracture or describing an X-ray. And this is roughly the formula that you would use to comment on and describe a fracture in real life. So you start with the patient's demographics. So this is an X-ray of Mr. Smith, age 45, taken on the 19th of May at 11 AM. Then you describe the fracture patterns and the bones. So this X-ray shows an oblique fracture in the middle segment of the left femur. Then you'll describe any deformity. And so this is describing the distal part of the fracture, so the bit that's furthest away from the center of the body. So in this case, the fracture is angulated by 10 degrees, displaced laterally 50%, and shortened by 10%. And then if you've seen the patient, you can comment then on any soft tissue damage or whether it's an open or closed fracture or any neuromuscular status. But that's basically a brief formula if they say, well, can you describe or present this X-ray of a fracture to me? And then this is just to demonstrate some of the terms I've just used. So undisplaced, basically there's been a fracture, but the bone is still in the same position. Impacted is where the two segments of the bone are kind of driven into one another, and they overlap. Angulations, there's some misalignment, one's at a different angle to the other. I'll describe that in degrees. Displacement is shifted slightly, either laterally or medially. And then rotation is where the broken off fragment has shifted round, but often you'll need two different X-rays to see that. So you'll need one from the front and then one from the side. Right, so another SBA. Okay, cool, very nice. So this question was about fractures of the neck of femur, and it's, again, very classic, comes up in question banks all the time. So this X-ray is showing a subtrochanteric fracture of the femur, and as you correctly said, the appropriate management is using an intramedullary nail. So we'll go through some of the different types of femoral fractures and the managements. So a little bit of anatomy. So this is what people mean when they talk about intracapsular and extracapsular fractures. So the femoral head is enclosed in this capsule, which is made up of the ligaments. So the ischial and pubofemoral ligaments create this capsule around the femoral head. So intracapsular is inside of this capsule, extracapsular is outside of that. And then these all join on this line, as you can see on the diagram on the right, just on this line separating the blue and the red segments. And then you've got the space in between the lesser and the greater trochanter, the intertrochanteric space, and then this sort of orangey, pinky segment below that is your subtrochanteric fracture. So that's your terminology. Just in this bottom right corner, we've got the Garden class of Garden criteria. So one is Garden 1 is incomplete separation, so incomplete fracture. 2 is complete fracture with no displacement. 3 is a complete fracture with partial displacement, and then 4 is a complete fracture and complete displacement of the femoral head from the neck. So another bit of terminology there. And then in terms of the fractures themselves, here are some examples just to demonstrate it. So the top right is your intracapsular fracture. They talk about the Shenton's line, which I've not displayed very well here, but this is the line that runs nicely up the femur, and then causes a nice curve along the pelvis. Then on the left, we've got an intratrochanteric fracture, where you can see the fracture line runs between the two trochanters. And then in the bottom right, we've got a subtrochanteric fracture we had in the question where it's been severed below that level. And then the management of intracapsular fractures first, and this depends on the severity of the fracture and also the habitus of the patient. So how active, how mobile, how old they are. So the reason that you replace the femoral head is that it's supplied by a retrograde blood supply. So that means that the blood vessel will go down past the femoral head and then loops back up. So if you fracture it, you can sever that, and the blood supply won't then get to the femoral head. And if it doesn't have blood supply, it necroses or dies and breaks down. And then in older, frailer individuals, they're more at risk of this happening and the blood supply breaking down, and have this significant risk of avascular necrosis. So what you do in elderly individuals is you replace the neck and the head of the femur. So that's a hemiarthroplasty, is where, so it's the one in the middle, you just replace the femoral neck and head. And this tends to be used in frailer patients who are immobile. It's just to prevent the avascular necrosis. It's not really going to improve their mobility. Then on the left, you've got your total hip replacement. This is where both the femoral head and the acetabulum are replaced. And this is used for greater mobility. So this is used in your slightly older patient, but who has good mobility, walks around a lot, likes to go for walks in the park, walks to the shop, and then has unfortunately fallen over, fractured their hip. And you do a total hip replacement in them. And then on the right, I've included what you do in a younger patient with a hip fracture. And that's something called a cancellous screw. And so that's where you get a screw and it screws along the neck of the femur up into the head, and it would use to preserve the bone, which should hopefully try and reduce the risk of arthritis in later years. Now, the management of your extracapsular fractures. So you've got two options here. So you've got your basically the management here is based on providing support that's perpendicular to the fracture. So the dynamic hip screw, you've got a fracture line that runs between the two trochanters. So you need to get support that crosses over that and holds it together. So that's what the dynamic hip screw does. And then it just holds that in place, stops that fracture from slipping backwards or forwards. And then it allows compression, which is why it's dynamic. It allows compression to allow the bone to heal best as possible. And then in the subtrochanteric fractures, it's the same management as you might do in a femoral shaft fracture, whereby you've got the fracture line running through the bone, so you need the nail that holds the two bits together. These are pretty bad fractures, so the nail's there to prevent the lateral movement of either fracture. Right, another SPA here. Yeah, cool. Very nice. Apologies, this is a bit of a past med question, but this is a common fracture, basically, so the Colle's fracture. And basically the dorsal displacement described is in reference to the distal fragment. So that's the bit of limb that's furthest away. And in a Colle's fracture, it's the whole hand that moves almost backwards. If you think about it, as you would fall onto your kind of outstretched hand, the wrist would go forwards, the hand would go backwards, and then that kind of dip down is your dinner fork abnormality that they talk about. So this, just to go through a couple of the other ones, you've got the Smith's fracture is probably the other one to really know about, and it's like a reverse Colle's fracture. So they'll fall on a closed fist, and then the bit of the hand will go forwards instead. I said sort of the eponymous fractures are loved by question banks and stuff, but I think this is something that can be for rote learn. So yeah, just to go through a few of the fractures. So just discuss the Colle's fracture there, and you can see this dinner fork abnormality on the left here. And yeah, the management is just closed reduction, then a splint, cast, immobilization. Happens falling on an outstretched hand, and then Smith's is the opposite. Another sort of classic question or some criteria to be aware of is the Weber's classification, and this is basically describing the fracture in relation to the syndesmosis of the fibula and tibia. So that means the point at which the two bones meet, which is roughly at the level that these letters are at. And so then in Weber's A, the fracture is below the syndesmosis, and can be treated quite easily with a boot or below the knee plaster. Then B is the most common. This is at the level of the syndesmosis, and then for this you'll need some plaster. And then the C is a fracture above the syndesmosis, and this is quite an unstable one because it's higher up in the fibula, and so then we'll need some surgery for that. Okay, and then humerus fracture is something that's quite useful to know about, I think, because what this can test is the nerve supply in the hands, or hands and the arm. So you've got your median nerve, ulnar nerve, radial nerve, and axillary nerve that run along the humerus, and depending on where in the humerus the fracture happens, that can cause damage to one of the nerves. So if you get this fracture at the top of the humerus, the proximal humerus fracture, there's a risk of axillary nerve damage. This also happens with your shoulder dislocation, and the way you test this is your loss of sensation over the regimental patch, which is just a little patch of skin on the shoulder. Then if you fracture the humeral shaft, if you can see on the right of this picture, the radial nerve crosses very close to the humerus at the back. So if you fracture it in the middle, you can damage the radial nerve, and what you'll see there is a wrist drop. There'll be loss of wrist extension as the radial nerve supplies the extensors to the wrist. And then you've got a supracondylar fracture, so a fracture above the condyles can damage the median nerve, which runs close there. And then if you fracture one of the condyles, you can see the ulnar nerve runs right alongside there, and you can get ulnar nerve damage. So it's just quite nice to know a bit about that, because that's a common question as well. And then here's just a couple of examples. So on the left, you've got your humeral neck fracture, in the middle, the humeral shaft damaged, and then your supracondylar fracture on the right. Then another very common fracture is a clavicle fracture. I think it would be a bit mean, but just something to look out for when you're going through your chest x-rays, because it can often be hidden in the top corner. But again, a very common fracture. And then just a few more here. You've got just some examples of some tibial and some femoral fractures, just to get to grips with. It's often quite good for exams to go through some Google images of common presentations, whether that's chest x-rays or CT heads or something. But it's quite useful because often people setting exams aren't that creative in searching for pictures. Right, another SPA here. Okay, very nice, very nice. So this is a question, it's another common scenario you might see in A&E or the fracture clinic. What you've got is a young man who's fallen over after a night out and then put his hand down to protect himself, and in doing so, he's just slammed his scaphoid into the floor and fractured it. And this doesn't often show up on an X-ray immediately. So if you suspect a fractured scaphoid, such as in this question, then you need to bring them back to the fracture clinic in sort of 7 to 10 days to arrange another X-ray and check for a fracture. The issue with this fracture is that the scaphoid bone, a bit like the head of the femur, can be at risk of avascular necrosis, and yeah, so where the blood supply gets impaired again, and so it's key to bring them back and check that this hasn't happened. Right, I think this is the last SPA. So let's get that up, and then I'll go through a few things for the OSCE, which is often another common concern. Yeah, very nice. So hopefully a nice, easy one to finish. Another fairly common scenario, someone coming in having felt a pop in their knee, a twisting injury with a pop sensation, and then instant swelling is very characteristic of rupture of the ACL, the anterior cruciate ligament. And then in addition to this, in this question, they've told us that a Lachman's test is positive. The Lachman's test is one of the special tests in the knee examination, which tests for an ACL rupture. A good differential for this is a meniscal tear, which will also be painful and may pop, but meniscal tears tend to swell roughly 24 hours after the injury. And the patient may also experience some sort of locking of the knee in a meniscal tear, and that's as the cartilage can fold over and can prevent the knee from moving in a full range of motion. Right, so some OSCE stuff. I wanted to touch on some OSCE stuff because there's pretty much guaranteed to be an ortho exam in your OSCE. So one station they'll say come and examine this joint, so the hip or something. The good news is I think they're actually pretty simple, and the reason for that is there's a structure for all of them which is the same. And if that's the only thing you remember when you go into the station, you just remember that structure, you'll definitely pass the station. And then there's a few added bits extra you can do and you'll get the top marks. So this is your basic structure. And key things that people often forget is the basics. So your wiper, the start, wash your hands, introduce yourself, explain to the patient what's going to happen and get permission for that to do the exam, and then expose the joint, reposition them to where you want to be, and you're off to a great start in the station. And then the first thing you do in any examination, again, is a general inspection. So look around the bed for any clues, look at the patient for any more clues, and then once that's done, you can move a bit more joint specific. So with an ortho exam, split it into 3 key sections: look, feel, move. And then you can do the special tests and the function if you've got time. So looking at the joint, what you're doing there is basically going through your dwarf's mnemonic. So are there any deformities, anything obvious? Any obvious muscle wasting, asymmetry comparing the 2 joints on either side? Are there any rashes, abrasions, injuries to the joint? Any fasciculations or obvious like muscle wasting as we've gone through, and then any scars that might indicate a previous injury or a previous surgery. So once you've had a look, then you can have a feel of the joint. And key things to think about when feeling the joint is assessing for the temperature, for any effusions. Is there any signs of it being infected, hot, swollen? And then you can feel the soft tissues around the joint and the muscles. So for any tenderness, wasting or tension in the muscles. And then you can move on to the bones of the joint, feeling for any pain, discomfort, abnormalities. And then assess the movement of the joint, as the whole purpose of a joint is to allow movement. So you get the patient to actively move themselves first, and then you can passively move that joint around afterwards. And things to think about there are, have they got a full range of movement? Is there any weakness of movement or any pain moving? For instance, can you passively move the joint but they can't actively move it, which might suggest a muscle injury? And then, so I've put this slide together basically as a rough overview of the ortho, the joints. And so I've got the look, feel, move sections in the middle, and these are the things to look for, and then a few more specific things for each of them. So for instance, assessing the lordosis and the kyphosis in the spine, or assessing the elbows for rheumatoid nodules, and then the specific movements in each joint, because of the different types of joint, there are a few different ones. And then also I've put in the special tests, the things that I think are probably the key ones to remember in each test. So I think if you kind of go through this when you're doing your OSCE practice, or just go through that, and I think that should be a good overview of pretty much all you need to smash an ortho station. And then these next few slides are basically the joint pathologies that you might be looking for in a joint exam. So for instance, if we take the neck, some key things that you might see if you're looking at the neck: degeneration of the spine, so osteoarthritis. You can get some nerve palsies, so yeah, you sort of Herb Duchenne palsy, which is your traction injury, and then Klumpke palsy, which is a compression injury of the brachial plexus. These commonly happen during birth. Some other things, thoracic outlet syndrome, where you get a compression of the nerve, artery and vein, often due to a cervical rib. The shoulder, so just a little bit of shoulder anatomy. You've got your rotator cuff, and that's essentially what you're assessing. And then other things like dislocation, cartilage tear. Some key things I've put in here. So adhesive capsulitis, which is your frozen shoulder, classically a middle-aged diabetic female, and they can't externally rotate their shoulder. It's almost stuck. They can't move it. Then you've got your dislocation, 95% majority are anterior. Then the other ones, you've got posterior dislocation, which happens in epileptics or lightning strikes, bizarrely. And rotator cuff tears, things you might look for in your special tests, impingement. The elbow, the two main things here are your lateral and medial epicondylitis. These are colloquially known as the tennis elbow, the golfer's elbow. Lateral epicondylitis, tennis elbow, basically it's when somebody's playing a backhand, they snap their wrist back. So it's repetitive wrist extension. And then you get pain over the lateral epicondyle, as that's where all the wrist extensors have their common origin. And then golfer's elbow is where golfers kind of snap their wrists over when playing a shot. So that's caused by pronation, flexion at the wrist. And that's pain over the medial epicondyle, because that's the common flexor origin. Hand and wrist, there's lots of things, and particularly osteoarthritis, rheumatoid arthritis will give you lots of classic hand signs. But some other things to think about, like we went through the scaphoid fracture, carpal tunnel syndrome, which is what your special tests are doing for. So your Phelan's test, where you compress the carpal tunnel and see if it produces tingling, and then the Tinnell's tap test, where you tap on the carpal tunnel, and it again produces the same symptoms. Hip, we went through hip fractures, but some other key things to look for maybe in an exam is some impingement, or a fixed flexion deformity. And then trochanteric bursitis, which is the bursa overlying the greater trochanter. It can get inflamed, and it's very, very painful when you press over there. This is something to always check for when you're doing your feeling of the hip joint. Knee, lots of things, but classically ACL, meniscal tear, good ones to know about, as they tend to be the most severe. The most commonly injured ligament in the knee is the medial collateral ligament. And then Osgood-Schlatter is something that happens during growth, where the muscles and bones grow at different rates. And so the bone grows, but the muscle then stretches and pulls a bit of the pulls the tibial tuberosity outwards, can be very painful. And then foot and ankle, Achilles tendon rupture is a classic. There's lots of things to look out for in SBA questions there, particularly anyone who's been prescribed Cipro, or if they've got Angspond classically. And this will say something like it sounded like a gunshot, or felt like somebody had stamped on their ankle. And then this Simmons test will be negative, will be positive, whereby there's the tendon's completely snapped and squeezing the calf doesn't produce plantar flexion of the foot. Then inversion injury, basically anybody who's played sport probably has had one of those, very common, and can get ligament damage from that. And then just these final few slides are on some pediatric orthopedics, and there's pretty much only 3 things you need to know for now, basically. So developmental dysplasia of the hip, which happens in newborn babies where they're born. Okay. The problem with that is if that's not picked up, they'll grow up and start walking on a hip joint that is not fully articulated, will cause very early onset arthritis, loads of problems. So there's tests you do in newborn screening exam for that. And then Perthes disease, which is avascular necrosis of the femoral head in younger kids, and it causes a destruction of the femoral head, and again can cause hip problems in a young child. And then SUFI, or slipped upper femoral epiphysis, is where the growth plate is quite weak, and it occurs in obese young teenagers, whereby there's too much force going through the growth plate and it just severs, and the femoral head slips off. So just the key things to pick out for these questions, you can basically work out your answers from the ages. So DDH will occur in newborns, and then it might say there'll be like a 20-year-old, 30-year-old person who's got arthritis in the hip and they don't know why, but they didn't have any newborn screening tests or something like that. Then Perthes disease occurs in kids age 4 to 8, 4 to 10. So if there's something around that, a limping child with no obvious signs of infection, that's a good answer there. And then SUFI, like I was saying, 10 to 15-year-olds tend to be obese with this loss of internal rotation, and then fix that with a screw. So thank you all for watching. I've just got a few resources here, just some suggestions of useful things. OSCE resources, I'm sure you know already, but Geeky Medics, OSCE Stop, Simple OSCE, all fantastic to go through. Loads and loads of materials there, and really useful. And then lastly, just to say thanks for watching. Really hope that these are useful. I've put my email up there if you have any questions about anything on the lecture or anything in general, orthopedics, 4th year, drop me a message there. And then I've attached the feedback forms here. And really appreciate if you fill these out. I'll attach the forms to the YouTube recording, so if anybody's watching this later, again, really appreciate your thoughts, so we can tailor these sessions and make them as useful and as interesting as possible. But otherwise, thank you again, and have a little look through the chat now and see if there are any questions. Are there any pressing questions in the chat that you guys didn't manage to get through?
I think we're probably all good, so I'm going to stop recording there.
Cool.
How can we access the slides? We've put them on Google Drive, the link to which is in the SPLICE Year 4 group.